Now we're going to focus specifically on the mhGAP training program that we formulated and conducted. This was a noble initiative by the Royal College in collaboration with Health and Medical Education Department of Jammu and Kashmir with support by WHO Geneva. This basically is my profile on the Mental Health Innovation Network, which is run in collaboration with World Health Organization, Grand Challenges Canada, and London School of Tropical Medicine. Before explaining the program, I would like to just acknowledge the people and the various stakeholders who provided advice and support in my project. I would like to acknowledge the role of the entire mhGAP team, my teachers, my friends, my colleagues, and family members. I would also acknowledge the support of faculty and staff of Imam Hussain Al Islam Hospital in Kashmir, who supported us in conducting a few pilot training project program before the launch of the mhGAP project in Kashmir. This is a photograph of the Imam Hussain Hospital based in Srinagar, Kashmir. I would like to offer my thanks to Professor Rachel Jenkins, she is the Emeritus Professor of International Psychiatry and was the research collaborator on behalf of World Health Organization. It was Professor Jenkins who inspired me to take this project. I met Professor Jenkins in one of the congresses of the Royal College of Psychiatry where she was giving a presentation on the work that the Royal College has been doing in Iraq. I would like to offer my thanks to Royal College of Psychiatry and to Professor James U. Bailey, the immediate past president of the Royal College of Psychiatry and current chair, Academy of Royal College, United Kingdom. Professor James U. Bailey was responsible for approving the proposal of the mhGAP project on behalf of the Royal College of Psychiatry. This is our president. This is our president, Professor James U. Bailey. This is at the Congress in Birmingham this year. I would like to offer my thanks and acknowledge the role of support of President of the Royal College of Psychiatry, Professor Sir Simon Wesley, for his approval and signing of the Memorandum of Understanding between the Royal College of Psychiatrists London and the Government of Jammu and Kashmir. See on the right hand is Professor Sir Simon Wesley, the President of the Royal College. This is at the Pathfinder dinner, which was one of the important places where we initiated the second component of our project of students interactive program, which I'm going to describe later. I would like to offer my thanks to Iraqi subcommittee of the Royal College of Psychiatry London, especially Dr. Muhammad Al Uzri. This is a photograph taken by outside the Royal College of Psychiatry London with myself and my state coordinator, Dr. Muhammad Muzaffar Khan. Dr. Uzri is one of the authors of this report that explains the launch of the new Iraq mental health from Leicester. This is basically a summary of the annual report of Royal College 2014, in which Royal College acknowledged and considered the mhGAP training program as one of the achievements of the Royal College. I would like to offer my thanks to Dr. Shekhar Saxena, WHO Director and Substance Misuse and head of the mhGAP project in the world, who provided technical assistance to mhGAP project in Kashmir along with his team. That is basically the profile of Professor Dr. Shekhar Saxena, the Director at WHO. This is the mhGAP forum this year at the WHO headquarters in Geneva, presided by Dr. Shekhar Saxena, Director WHO. Again, a photograph from the mhGAP forum. This is a photograph with Dr. Shekhar Saxena at the WHO headquarters this year, uh, where I attended the 7th mhGAP forum. It was at this forum that the mhGAP Kashmir was nominated by Mental Health Innovative Network as the most popular innovative project in the world. As mentioned earlier, I am thankful to Professor Vikram Patel for his advice, support, and guidance. This is Dr. Rahul Shindia, who is the principal investigator for Prime, who is receiving the award on behalf of Professor Vikram Patel. The award is being conferred by Dr. Salimur Rahman, Director of Health Services, and standing next to him is Dr. Peter Hughes, leading the team of Royal College to Kashmir. These were the views of the Professor Vikram Patel about the mhGAP project in Kashmir, which were presented to the mhGAP forum this year. Vikram Patel has also been named as one of the most influential people in the world by the Time magazine. I would also like to acknowledge and appreciate the excellent support of Government of Jammu and Kashmir to mhGAP project, which led it to being the best innovative project in the world at the WHO Assembly in Geneva, from more than 120 nominations by more than 100 organizations across the globe. This is the photograph showing that mhGAP Kashmir being nominated as #1 innovation out of more than 120 innovations. This is a photograph of the Mental Health Innovation Network team led by World Health Organization, Grand Challenges Canada, and the School of Tropical Medicine. This is Peter Singhal, head of Grand Challenges Canada, with Dr. Shekhar Saxena at the WHO forum in Geneva this year. I would like to acknowledge the support of the Government of Jammu and Kashmir for the excellent support for monitoring and evaluation phase of the mhGAP project 2014-2015. I would like to offer my thanks to Honorable Minister of Health and Medical Education, Chaudhry Lal Singh, Commissioner Secretary Health and Medical Education, Dr. M.K. Pandari, and the current Director of Health Services, Dr. Sumir Muthu. This basically I will be showing a photograph where the Honorable Minister for Health and Medical Education, Mr. Chaudhry Lal Singh, is giving an award of appreciation to CMO Honorable Dr. Kasana for his excellent guidance, support, and supervision to mhGAP trainees of District Honorable in the successful completion of monitoring and evaluation phase of mhGAP Kashmir despite massive floods. In which Dr. Salim Rahman, who initiated the mhGAP project, invited the team from the Royal College of Psychiatry standing in the background. I would like to acknowledge the role of the previous government. I would like to acknowledge the role of Honorable Minister of Health and Medical Education, Mr. Taj Mohiddin, Commissioner Secretary Health and Medical Education, Mr. Ghazanfar Hussain, Director of Health Services Kashmir, Dr. Salimur Rahman. This is a photograph showing the Honorable Minister, Mr. Taj Mohiddin, arriving at the inaugural function of the mhGAP training program, where Honorable Minister announced the signing of the MOU between the Royal College of Psychiatry London and the Health and Medical Education Department of Government of Kashmir. Honorable Minister announcing the signing of the MOU between the government and the Royal College of Psychiatry London. Dr. Peter Hughes discussing the mhGAP and MOU on behalf of the Royal College of Psychiatrists London. This is a list of the memorandum of understanding that the college has with various organizations, and if you clearly see, it mentions Institute of Mental Health and Health and Medical Education Department of Jammu and Kashmir as one of the organizations with which they had a memorandum of understanding. Again, various organizations across the globe with which college has a memorandum of understanding or affiliation. I am highly grateful to Director Health Services Kashmir of Salim Rahman, under whose leadership this mhGAP project became possible and successful. This is the annual achievements of the Director of Health Service Kashmir. It mentions that mhGAP Kashmir as one of the achievements of the government of Jammu and Kashmir. Now I would like to acknowledge the role of the mhGAP trainers. These are the list of the trainers who came for in the first phase of mhGAP training that extended over 2 weeks. These are all mhGAP trainers. This photograph is being taken in one of the houseboats after the completion of the mhGAP training. The training included trainers from both UK. We had a local Kashmiri consultant who is a consultant in UK but was part of the team, Dr. Sajad. If you see him standing next to me on the right. This is the second team of mhGAP that came in 2014. I think Peter Hughes, Sajad were part of the previous team. Ryland and Pamela Morley, they joined the second team. This is award of appreciation being given to the team by Dr. Salim Rahman at the completion of the training. We would like to appreciate the role of the mhGAP trainees. These are the photographs taken at the end of completion of the mhGAP training of 2013, and this is for 2014. I would like to offer my thanks to Institute of Mental Health Neurosciences in Kashmir for their support in conducting the second phase of mhGAP training. I would like to offer my thanks to J&K Police, especially Asam Sahai, Additional Director General Police, and Dr. Mohammad Muzaffar Khan, Director Police Direction Service and State Coordinator for mhGAP project in Kashmir, for providing foolproof security to the mhGAP trainers. The award of appreciation being given to Asam Sahai, to Dr. Mohammad Muzaffar Khan. I would also like to acknowledge the role of the NGOs, especially Health Foundation, its chairperson, Mr. Negar Shafi, ActionAid India, corporate sectors, Jammu and Kashmir Bank and TCI Siemens for their valuable support and contribution to the project. This is Mrs. Negar Shafi at the inaugural function of the first mhGAP training program. Panya, I would like to thank the people of the valley whose support and prayers made the mhGAP Kashmir a success as depicted in the photograph of the Mental Health Innovative Network. So this photograph, it shows a lattice window. This is a painting made by one of the renowned Kashmiri artists depicting a Kashmiri culture and behind which a woman is standing, raised arm, praying for the success of the project. Now, just going to having complete the acknowledgement, I will going to explain and go through the mhGAP training program and about as how we went about it, what were the problems we faced, and how we successfully managed to overcome those problems. This was initial recommendation of Professor Rachel Jenkins when I wrote to her about the program. If you see clearly, she mentioned particularly certain important things that we needed to take into consideration. Establish mental health professionals at district level who can support, supervise primary care staff, and organize regional mental health professionals for support and supervise district level support in her experience, which she feels were lacking. It mentioned it is these layers of support and supervision which are likely to be missing in Kashmir and which are likely to make a large difference to the long-term and sustainability of the impact of the training. If they are to give adequate support, these higher levels also need training about the mental health in primary care, which is so different from secondary care. So this is the role of training the trainers component, which will be focusing now that people who were trained, they will be specially trained, and other professionals and other psychiatrists will be trained to deliver training, develop health management information system for monitoring, assessment, diagnosis, treatment, and referral. That was the second phase of the mhGAP training program that we did. This was the outcome of my first meeting with Professor Sue Bailey, president of the then past president of the Royal College of Psychiatry, London. Clearly, she mentioned about the Iraq model and the role of Dr. Peter Hughes to work out a priority plan, what we would like to achieve in the next 4 to 5 years. We also sought advice from Professor Dinesh Bugra, who is the president of the World Psychiatric Association. We had a meeting with the World Health Organization, this was the outcome of the meeting, which was endorsed by Dr. Shekhar Saxena, that WHO will be providing technical support access to training material which WHO has given permission to use. They will be providing regular advice support as projects proceed, which they did. And it was agreed that I will be serving as the coordinator between the WHO, Royal College, and the Kashmir government. We also agreed to discuss how the mhGAP program could be implemented and integrated into the district mental health program, which was stressed both by the college and the World Health Organization. This is a statement of the president of the Royal College of Psychiatry. The Royal College of Psychiatry is committed to supporting members, providing mental health education across the world. Our volunteer scheme was set up with this core belief in mind. I'm very pleased that the college members are prepared to offer their time and expertise. I'm delighted this initiative has come to fruition, and thanks out to Dr. Akil and Dr. Peter for the hard work set in this training. I hope the participants find this experience enriching and rewarding. This basically is the mhGAP intervention guide formulated by WHO, which we used in our training. These are the various forms of teaching procedures or teaching ways which we can say we used, which includes having group discussion. This photograph is this is Professor Yusuf Masha. He was the ex head of department medicine, Government Medical College, Srinagar, and he attended the full 5 days of the mhGAP training. This mhGAP training motivated him to add another chapter of mental health to his book of trauma medicine. Dr. Peter Hughes supervising the group discussion, role play being conducted by Dr. Peter Hughes, presentation being given by mhGAP trainers. Of these various training teaching methods that we used, we evaluated them and sought the feedback from the trainees. Role play was considered the number one, followed by group work, case discussion, and lectures and case presentation were considered the last. This photograph is basically evaluating the results of feedback following the completion of the training. Once we completed the training, a report was formulated and which was submitted to the college. and the college with recommendations forwarded those report to the that report to the government of Jammu and Kashmir. You see, this report had a covering letter to Director Health Services, Dr. Salim Rahman, with copy to Commission Secretary Health, Mr. Ghazanfar Hussain. This chart basically depicts the number of patients that visit the outpatient of the psychiatric disease hospital. You see, over the period of years, it has been on the rise due to political turmoil that has been there going on there for the last couple of decades. We did a survey before starting the training, and we asked all the trainees to write down the number of cases and the type of cases that they had seen over the last 1 month before starting of the training. You see, 620 cases were new, and the most common mental illness that they had seen was depression. This was the participant background in the first week of the training. Participant background in the second week of the training. Females being more in the second week rather than the first week of the training. This was the evaluation of the pre and post test results. We used the questionnaire that has been formulated by WHO, and we conducted this test before and after the training. See that before the training it was 68 and the results were increased to 84 in both the first and the second week of the training. This was the feedback regarding the training program that was delivered. We focused on clinical relevance, structure, and clarity of teaching. As you can see, in all the three modules, they were quite appreciated by the trainees. Again, overall score of week 1. Feedback results of relevance, structure, and clarity in the second week of the mhGAP training. Overall score. This is a photograph of me and Dr. Muzaffar presenting the poster to the Royal College of Psychiatric Congress in London after completion of the first phase of the training. Having completed the first phase of the training, in which we trained, as you can see, more than 100 professionals of various disciplines across the whole of Kashmir. In fact, the interesting fact was that Dr. Salimur Rahman issued order so that the doctors and nurses could be deputed from all 12 districts of Kashmir. And besides the government sector, as mentioned earlier in my earlier presentation, we ensured that the NGO, the social workers, the police personnel, the teachers, and all stakeholders were involved as recommended in the initial presentation as one of the reasons that can lead to success of the mental health program in the community. We started the second phase of mhGAP training program after 1 year in 2014. We asked the trainees who attended the first session to attend the session, and we did evaluated the evaluated and sought their feedback about the experience over the last 1 year with regards to use of the mhGAP training with regards to the patient care. This is a list of attendants. Almost 65 of them reported back and came for the training. Again, this was the feedback regarding the refresher course which we conducted, in which the doctors and paramedics and other professionals who had done the training shared their experience with regards to the use of mhGAP intervention guide and how it was helpful in identifying the various patients in their day-to-day work. We repeated the pre and post test training test that we did in the 2013. So in 2014, with the training ran only for 1 week, but we had two groups running in rather than rather than the groups running for whole 2 weeks. Again, a group feedback of 2014 mhGAP trainees, clinical relevance, structure, clarity of teaching, and overall feedback. Again, feedback of group 2. This is the feedback that has been provided by the trainers. I would like to share the feedback by Dr. Lucy Porter, who was at that time a psychiatric trainee at the Mosley. She mentioned that mhGAP training in Kashmir was a fantastic experience for me, through which I feel I have developed multiple skills, including the planning and delivery of training to a multidisciplinary audience. Our stay at the Regional Institute Health and Family Welfare was great and could not have been more welcoming. I hope there will be future mhGAP training, further mhGAP training in the future. Dr. Lucy Porter went on to conduct mhGAP training programs in Zimbabwe. This basically is her interview after completion of the mhGAP training in Zimbabwe, in which she specifically mentions about her experience in Kashmir. She mentioned that evidence-based for global mental highlights high burden of mental illness in low-income countries. Therefore, it is crucial that services for mental health are scaled up in a meaningful way. Lack of human resources is one of the major barriers, and creative solutions needs to be implemented. A compelling research that supports assisting where health workers with a shorter duration of training can provide valuable care for people with common mental health disorders, enabling them to lead healthy, productive life. mhGAP training in Kashmir was an incredibly effective experience or example of this. This was another feedback that was given by one of the mhGAP trainees. This was an article that was basically got published in one of the newspapers, in which he mentioned that they learned a wonderful term named human placebo. A galaxy of doctors, psychologists from Royal College, whom I could not imagine of meeting even in a dream, taught the basics of human care to the patients having psychiatric ailments. Galaxio again, he mentioned at the end that they were quite impressed about the quality of the training that was being provided. This is the overall feedback by the trainers. Mentioned that mhGAP training was well organized, well designed, easy to teach and learn from, and very applicable. This was the paper that was published this year by Dr. Ireland and Lucy Porter, both psychiatric trainees who had come as part of mhGAP to Kashmir. If you see, they clearly mentioned that by participating in the volunteer program have helped them to experience the key issues of global health, such as cultural factors, stigmatization, availability of resources, structures of the various health systems. This was the feedback by WHO from WHO headquarters Geneva after the completion of the mhGAP training. It also mentioned about the Manchester orientation workshop. That was the training the trainers workshop. That was second workshop conducted by Dr. Peter Pugh, Dr. Sophie Thompson, both of whom came to Kashmir in the first year. And the first one was conducted in March before we uh, before we started the first phase of training, which was attended by more than 100 participants at that time. Following the completion of the training, our aim was to get a memorandum of understanding signed between the Kashmir government and the Royal College of Psychiatrists, London. So we're trying to seek the views, opinions of the various experts around the globe as to what should be incorporated into the terms and conditions of the memorandum of understanding. These were some of the recommendations that were some given by Dr. Shekhar Saxena, Director WHO, mentioned about training to primary care providers in treating disorder, especially related to stress. WHO has a new manual for this, psychological first aid training to healthcare, social care, emergency, police, and staff. This was the covering letter that came with a MOU that the second batch of mhGAP trainers brought with them. It was brought by Dr. Peter Hughes, and in which it is signed by Professor Sir Simon Wesley, who is the current president of the Royal College of Psychiatrists, London. It's addressed to Mr. Gazafar Hussain, the Commissioner Secretary, Health and Medical Education, who signed the MOU on behalf of the Kashmir government. These are the main components of the Memorandum of Understanding: capacity building in primary care to deliver quality care and mental health service across the Kashmir region, enhance accessibility of mental health care to rural areas, good quality secondary care advice to primary care, use of mhGAP intervention guide as one of the tools of capacity building, principles of psychological first aid, enhance public education of mental health to overcome stigma against mental health, advocacy and respect for the rights of patient mental health, intersector collaboration to enhance mental health well-being, develop training in mental health at primary and secondary care level, mental health training to providers of education and social care, and ensure high quality supervision, monitoring, evaluation in the provision of mental health care. Having completed the second phase of training, in which we basically specifically focus on one district of district Ganderbal, all most of the doctors we focus on district Ganderbal so that it was easy to monitor and evaluate the outcome rather than focusing on doctors from the entire valley. Well, due to start the monitoring evaluation project, and but unfortunately there was a massive flood which start happened just 1 week after the completion of the second phase of training. I'm going to share with you some of the photographs to show the extent of damage the floods caused in Kashmir. This is the center of the city of districts of Srinagar, the capital of Kashmir. This was the aerial view of the flood in Kashmir. This is again the recommendations of Professor Vikram Patel regarding the monitoring evaluation, which he stressed upon the focus on the competencies rather than on attitude. So that was the reason, that was what we were focusing on. And to monitor the competency, it's quite important to conduct the supervision, which was one of the important components of our second phase of training, as well as monitoring and evaluation. Unfortunately, this monitoring evaluation phase got delayed by 6 months, and following that, we had to conduct several refresher courses to refresh the memory of the doctors who had undergone training before the floods. We managed to get the ball rolling, and these are the list of the uh, healthcare centers that participate in the monitoring and evaluation phase of the mhGAP Kashmir. This is one of the registers that got we printed and that was used for recording the data in the primary healthcare centers. This is the summary of the number of cases you see in May. In the 3 months that we use as the pilot project, this is the number of cases. These are the number of cases you see seen in the month of May. This is in the month of June, and month of July. So total number of psychiatric cases seen in the 3 months. You see depression topped the list. This was evaluation of about treatment and use of psychological therapy and referral. In fact, non-prescribing professionals, they used to provide counseling and then refer them to the specialist. But the specialists who used to, psychiatrists who used to come to Ganderbal twice or thrice a week to see these patients, or the complex cases ended up being referred to the tertiary care center. Number of cases identified by prescribing and non-prescribing doctor. You see, interestingly, non-prescribing doctors have identified more cases than prescribing doctors. Now, second important component that we needed to focus on was the supervision, which was a local supervision provided locally and the distant online supervision. I'm going to just focus on the distant online supervision. We're grateful to King's College London who allowed us to use this software devised by them called Medicine Africa. It's an online platform that connects doctors, health workers, and other professionals. It was built for the Kashmir King's That Somalia project and support other partnerships between UK and Palestine, Kashmir, and Uganda. It can be used for educational training to improve clinical reasoning, teaching faculty to conduct better examination or learn research methods, strengthening or developing clinical services, giving tailored advice, planning or collaborating or health service research or data collection. See, these are some of the projects, some on the Medicine Africa. Fiji, we got two projects, Kashmir UK Global mhGAP Supervision Partnership, and the second was Kashmir UK e-learning interactive super partnership, in which the medical students of UK and the medical students of Kashmir interacted online and discussed various modules of mhGAP intervention guide. Now, this is the list of the trainees and trainers who provided them online supervision. I'm thankful that all the trainers who had come for mhGAP training were available and contributed to providing online supervision for mhGAP trainees. I would like to acknowledge the work done by Said Owais, who was a research fellow employed for mhGAP Kashmir. Having completed the project, we analyzed and evaluated the results and submitted it to both Royal College and World Health Organization. The results were presented by me to the mhGAP forum. I'm just going to summarize give a brief background about what the mhGAP forum is. The vision of the mhGAP forum is to provide effective and humane care for all patients with mental, neurological, and substance use disorders, particular focus on the vulnerable ones in low and middle income countries by improving service delivery, reducing the treatment gap, and increasing the financial and human resources for mental health care. This is the mhGAP forum this year. I was representing my institute. I'm going to basically summarize the mental health action plan that was devised in 2012, and the aim is to 2012 to 2020 to implement various proposals that were drafted in the fourth mhGAP forum. It specifically focused on comorbidity with physical problems and coexistence of mental disorders, the linkage of mental health with HIV, AIDS, and NCD, reference to discrimination and disabled people, the linkage with social determinants of health, nutrition, and environment aspects, inclusion of spirituality as a dimension. That's interesting. The quality aspect of health and social services, the concept of culture, acceptability, and inclusion. Discussion of suicide not to emphasize only the young in terms of vulnerable population, intervention of suicide prevention for young people, research component, and to add more information on the models being implemented on scaling integrating mental health into primary health care, support of health care, support of care to caregivers and families, issues the important parallel of NGOs, mental health issues of women and girls, mental issues in children, and the role of e-medicine, e-mental health tools in implementation. The very issues that were raised that there are weak links to WHO stated priorities, international partners were associated with all activities, TIC was not strongly enough reflected, more positive rebranding of mental health needed. It should reflect mandate for a greater integration and should include the importance of spirituality for well-being. To clarify as to whether all the implementation options were optional or were some were priority action, to make the action plan discourse more global than a Western public health model and more emphasis on transcultural issues and potential values of other cultural models. I basically submitted a paper to the British Journal of Psychiatry in which we mentioned that how mental Western media can learn from mhGAP and mhGAP can learn from system models. So the give and take approach rather than just blindly accepting or endorsing the Western model, which we then find it difficult to integrate, implement in our culture. India was part of the member states when in 2012, and they had the privilege of sponsoring along with Switzerland and US the resolution of mental health executive board of WHO in 2012, which led to the development of global mental health action plan. In this issue, see, it clearly acknowledge the evolving threat of mental disorders and action needed as soon as possible. I think depression was the theme for the World Mental Health Day in 2012. It mentions about the need to revise the district mental health program and with substantial financial allocation. And India welcomed the technical assistance which WHO continues to provide across the globe. These are the various international and national partners who are involved in implementation of mental health action plan. See, it is Institute of Mental Neuroscience in Kashmir, India, is one of the international partners in the implementation of the mental health action plan. Finally, I like to share this slide. This is a photograph from inside of a Concorde plane. That's the only plane which has got no class distinction with regards to service provision, which I think needs to be the fundamental principle of our project. I would like to thank everyone for participating in this webinar. So if you have any question, uh, feel free to ask. You can write, or if you can want to speak,